Okay, hello. I would like to welcome you to this OncoJournal Club. I will be the moderator, and my name is Richard Cathomas. I'm an oncologist at the Kantonsspital Graubünden in Chur. And I have two discussants that have joined me. This is Dr. Frank Stenner from the University Hospital in Basel and Dr. Philippe von Burg from the Kantonsspital Aargau. Welcome. I'd like to start with today's paper. So can we have the next slide, please? The paper I have chosen is about the evaluation of a different docetaxel regimen for patients who have metastatic castration-resistant prostate cancer. It's a randomized phase 3 trial that was performed mainly in Finland and was recently published 2 months ago in the Lancet Oncology. Next slide, please. So I think the background is well known to most of you. There have been 2 large phase 3 trials testing docetaxel chemotherapy in metastatic prostate cancer patients who are resistant to anti-hormonal treatment. The better known trial is the TEX-327 trial, published in the New England Journal in 2004. In the same issue, there was a second trial from the SWOG group. Both showed that docetaxel improves survival in these patients and can also improve symptoms. So the usual regime in both of these trials was to give docetaxel 75 milligrams per meter square every 3 weeks. So we call it Q3W as a standard. In the TEX-327 trial, there was another arm with weekly docetaxel that, however, did not meet the primary endpoint of improved overall survival and therefore is not considered to be a standard. The problem of docetaxel chemotherapy is myelosuppression and the febrile neutropenia, as we all know. Then patients experience fatigue, diarrhea, nail changes, and neuropathy, and therefore docetaxel had it quite difficult to become a proper standard despite proven overall survival benefit. Now, this trial tests the hypothesis that giving docetaxel every 2 weeks might be better tolerated and therefore could lead to a longer time on treatment and an improved outcome. Next slide, please. The design is a fairly simple design of this trial. It's an open label, of course, randomized phase 3 trial. The experimental arm is docetaxel 50 milligrams per meter square every 2 weeks, and the control arm is the standard 75 milligrams per meter square of docetaxel every 3 weeks. In both arms, patients received prednisone 10 milligrams per day. Inclusion and exclusion criteria are the usual criteria we find in all of these trials. So it's all metastatic castration-resistant prostate cancer. They had no prior chemotherapy and they have adequate organ function. According to the protocol, a dose reduction was planned if the patient had grade 4 hematological toxicity or if he had grade 3 or more non-hematological toxicity. And the dose reduction steps were from 75 to 60 milligram per meter square and then to 50, and in the 50 milligram arm from 50 to 40 and then to 30 milligram per meter square. The primary endpoint that was chosen is time to treatment failure, which includes progressive disease, also progressive PSA only, unacceptable toxicity or death of the patient. Secondary endpoints were objective response, PSA response, and overall survival, as well as time to progression. Next slide, please. So these are the patient characteristics. Between January 2004 and May 2009, so it took more than 5 years to recruit 361 patients in 11 centers in Finland, Ireland, and Sweden. The median age was 68, 69 in both arms, with a large range up to 85, 87 years. Most patients had a slightly impaired performance status with performance status of 1, some with performance status 2, but very small numbers. It's the usual that most patients had bone metastases, and it's interesting to note that more than 50% of the patients had received radiotherapy to the prostate, which probably is due to this treatment being very popular in the countries that included patients. But I think this is an important point, and it's different from the patients we see. Next slide. To the endpoint, so primary endpoint was time to treatment failure, and we can see that there is an improvement in the time to treatment failure in the experimental arm, where docetaxel was given every 2 weeks. Numerically, it's only 0.7 months, so it's very small. However, it is statistically significant. It is interesting to see that the median overall survival is improved by 2.5 months in the experimental arm, so it's 19.5 in the 2-weekly docetaxel versus 17 in the 3-weekly docetaxel. Again, statistically significant. The PSA response was very similar and not different. Next slide, please. The toxicity, it's interesting to see that there is a marked reduction in febrile neutropenia as well as in severe grade 3 and 4 neutropenia. This certainly is an interesting finding. The other toxicities such as fatigue, diarrhea, nausea, and so on are pretty similar in both arms. And also there was no difference in neuropathy, nail changes, and in watery eyes. Next slide, please. So I think this has been a very brief overview of this paper. It's a very simple intervention to give docetaxel every 2 weeks instead of every 3 weeks. I think the trial is a positive trial in terms of that their primary endpoint of time to treatment failure was met, although there is a small difference. And I think that this is certainly a point that we need to discuss. And I wonder, and I would ask Frank Stenner first, whether he believes that the docetaxel every 2 weeks, such as given in this trial, can now be accepted as an additional standard chemotherapy for metastatic castration-resistant prostate cancer. Frank.
Okay, when we look at this trial, we see, as just mentioned, a positive trial in itself. But we have to put the trial into the context of the existing data. And when we look at the weekly docetaxel arm of this trial, we find it a bit inferior in the results compared to the TAX-3-7 study. So we see a little less overall survival in these patients, and we see some more adverse events, especially if you look at important parameters as neutropenia or neutropenia. We see higher rates in this trial. That is not quite explained by the authors why that was so.
Thank you very much for this very interesting insight and discussion. Philippe, what is your feeling about the paper?
I think this paper delivers data that in some way we were been waiting for, because the three weekly schedule was too toxic for some patients, and we all know that the weekly schedule was inferior, significantly inferior. There was all survival benefits compared to the mitochondrial chemotherapy, and this is a good alternative. And we already started. We did it sometimes before in RO, but now we have good data that shows us that it's right what we have been doing, and I think it's a good alternative for elderly patients, because toxicity shown here is less.
Yes, I think I completely agree with both of you. And it is especially quite a few men are afraid of having chemotherapy chemotherapy. And I mean, we all know that if we give lower doses of docetaxel, certainly to start with, we have a better tolerance of the treatment. And probably this can overcome this fear of the patients towards the chemotherapy. And so I'm glad that a group has undertaken this trial, which is a bit special nowadays that we see all these new compounds, but I think this is really an important trial. Now, the authors discuss in their paper in the end that they say, well, of course, it's only one trial, it's not a very large number, and certainly, like Frank has pointed out, the results in the 3-weekly docetaxel arm are inferior to what we were expecting, in fact. And therefore, of course, they say, well, we need more trials to confirm this. And I wonder whether you feel the same, or whether you feel maybe this is a waste of time and money. Frank?
I wouldn't go for another trial examining this question. And there are 2 reasons for that. First, I think we will a randomized controlled trial, and there have been other signs that this could be a working schedule before. So why waste more time on that? And second, I think that the area of docetaxel is probably close to coming to an end, when probably Cathomas will move forward in the first line. And I think, these kind of data are not really needed at that point. I think we really have a good option for the data of this trial, and I think the authors and the investigators must be congratulated to do such a trial. It's a very puristic trial with an old compound and a good way for our patients to improve the schedule. And for this, I think we should leave it at this and adapt it as an option for patients.
Yes, so certainly in your discussion, you agree with the editorialists in this same issue of Lancet Oncology, and I think absolutely the same. As Philippe von Burg has said, it's great that we now have nice data to use a schedule to give docetaxel every 2 weeks, but until we would have results from other trials, we would probably have different ways to treat metastatic castration prostate cancer. I definitely agree with that. So Philippe has already said you would and you have already changed your schedule in several patients. Would you change it for every patient, or do you choose according to age and performance status?
Not for every patient. There are still these critical patients that I think the weekly schedule is a good alternative for patients that you're not sure if chemotherapy is tolerable at all or not. But for most of the others, I think it will be the new standard. In fact, because of the less toxicity, it's the main reason for me.
Okay, thank you. What about you, Frank?
And comparable efficiency data with the 3-weekly schedule.
Okay. And you, Frank, will you change your schedule?
I found a very interesting part in the results when it comes to the time to treatment failure. And when they analyzed it in a subgroup analysis, they showed that the patients that were younger than 65 and those with good performance status and those with a lower PSA than 114, this was the patients. These were the patients that benefited the most from this kind of schedule. So I think we should be cautious and rather give a patient in a good performance status. Patients, great patients, are still candidates for the weekly schedule, but for younger patients in good performance status, I suggest this kind of scheme in order to have a possibly longer time to treatment in this scenario. So that's the group that I would focus on.
Thank you very much to both of you. I think we really here have seen a new, nice, and very easy to apply way to improve our chemotherapy for these patients. And I myself have also now, since the patient has come out, changed the scheduling in some patients. And my experiences personally are very good. And I will certainly continue to use it this way. And I think our time is over now. I would like to thank you both for your participation. It has not been easy to set it all up, but now we finally did it. Thank you very much.
Thank you very much, Philippe. Thank you very much, Richard.